Good afternoon. Yeah, so good afternoon, everyone. Welcome to Cardiology Round. So it's my pleasure today to welcome our guest speaker, Dr. Ming-Yen Ng. Dr. Ming-Yen Ng is known to many of us actually here. So he is a clinical associate professor at the Department of Diagnostic Radiology at the University of Hong Kong, and also the Hong Kong University Cardiac Imaging Massive Open Online Course Director. Several years ago, actually, Dr. Ng actually trained in Toronto, actually at the Toronto General Hospital as well. So this is when we actually met years back. So he is a fellow of the American College of Cardiology, Society of Cardiovascular Magnetic Resonance, and also the Society of Cardiovascular Computer Tomography. He's also a member of the board director, the board of trustee actually in these societies, and also a planning member of the RSNA annual program. He's also playing an important editorial role, being an associate editor of the Journal of Cardiovascular Magnetic Resonance, which is kind of the go-to journal in cardiac MRI, and also the Journal of Cardiovascular Computer Tomography. He has also received several teaching awards and has been awarded over $5 million US dollars in grant funding. And he's actively involved in research with unique interest in quantitative stress MRI, coronary artery disease, diabetes, and heart failure with preserved ejection fraction, 4D flow, and also COVID myocarditis. He has published over 80 peer-reviewed publications, including high-impact journals such as JACC Cardiovascular Imaging, Circulation Cardiovascular Imaging, European Heart Journal Cardiovascular Imaging, and also Radiology. So today he's going to talk to us about cardiac MRI developments, quantitative stress perfusion, and intraventricular 4D flow. Thank you, Dr. Ng.
Thanks, Andrew, for the very kind introduction. And it's wonderful to be speaking to you today. Although wish I was there with you, but currently I'm actually with my family in Ottawa, visiting some friends. So today I'm going to talk about cardiac MRI developments, specifically talking about quantitative stress perfusion and intraventricular 4D flow. But because these two topics are kind of there's not so much overlap between the two, I'm going to tackle them one by one. So let me just get my screen working. Okay, so these are the learning objectives which you should have got earlier. These are my disclosures. So for quantitative stress perfusion, in terms of the contents of the talk, I'm first going to talk about stress CMR and its evolution, then talk about how we perform quantitative stress CMR.
Sorry, you're not sharing the screen. We can see you. We can see your.
Oh, right. Hold on.
We don't see the slides.
Let me try again. Thanks for pointing that out.
I was able to see the slides actually, so it was actually going okay on my.
Now we can.
Yeah,
now it's okay. Yeah, thank you.
Okay, good. Okay, yeah.
Okay.
Okay, thanks. Yeah.
No problem. Okay, so I'm just gonna cover some of the contents of the talk. So just to explain, I was splitting the talk into essentially quantitative stress perfusion, and then in the latter half I'll cover 4D flow, and then for the last part of the quantitative stress perfusion talk, I'll talk about some of the future challenges. Okay, so for stress CMR, some of you have actually been doing CMR longer than I have, but the first stress CMR papers appeared in the 1990s when I was still at school. So things like Spice Girls and Friends were happening at the time. And in the journey of stress CMR, it's really moved from essentially a qualitative study over to a semi-quantitative methodology, and then finally to a fully quantitative method. So qualitative, just to explain what I mean by that, it's the way that we typically look at stress CMR, which is we have the perfusion images, a stress and rest perfusion, and we're essentially looking for perfusion defect. Semi-quantitative is where essentially people many years ago, so actually decades ago, had really worked out that what you could do is you could draw regions of interest and you could actually measure the contrast flowing into the myocardium as well as the blood pool. And you could use this to quantify something known as the myocardial perfusion reserve. So fully quantitative is different in that what is happening now is that we can actually measure myocardial blood flow. And this is really a major step forward for measuring myocardial perfusion because for once we can actually determine the actual amount of blood flow rather than producing a myocardial perfusion reserve, which is actually more of a ratio. So we're just essentially previously with semi-quantitative, we're essentially looking at an how much of an increase or relative increase there is in myocardial perfusion rather than the amount of blood flow. So here's just an example of what a stress rest perfusion map looks like on quantitative perfusion, and here's a stress MBF map which shows the actual values. So the issues with qualitative perfusion is really that you needed expert readers. And there's a condition known as coronary microvascular dysfunction, which is getting increasing recognition in the cardiology world. But this is something that actually we would struggle to identify in qualitative perfusion. Traditionally, we have been taught that to identify this, you need to look for a circumferential perfusion defect that's usually relatively transient. And sometimes it can be a little bit difficult to work out the difference between triple vessel disease and coronary microvascular dysfunction based on the qualitative perfusion method. So this was just one study that we did over in Hong Kong where we looked at using semi-quantitative perfusion, and we showed that in patients with non-obstructive coronary artery disease, but with chest pain, essentially already the semi-quantitative perfusion parameters was able to essentially differentiate those patients that were more likely to have adverse events compared to those that don't. So quantitative stress CMR, as mentioned earlier, measures or quantifies the amount of myocardial blood flow, and the units is milliliters per gram, and the gram is per muscle is relative to muscle, and this is based per minute. Then there is myocardial perfusion reserve, which is similar to what was measured with semi-quantitative perfusion, but in reality, the two parameters are actually different because of the way that arterial input function is measured. And then lastly, quantitative stress CMI has now become more of an automated feature. So in the past, semi-quantitative stress CMI, you'd actually have to draw all the contours yourself. But many of the new techniques for quantitative stress CMR are fully automated, which makes this much easier to translate clinically. So why do quantitative perfusion? So the interest really in quantitative stress CMR is really the fact that it makes it a little bit easier to look at, say, a visual read. So here you can see an example of a patient with almost a circumferential stress perfusion defect, and you can see here that there is generally a reduction in myocardial blood flow. You can also use it as a way of determining if there's adequate stress. And as mentioned, it's also handy in terms of identifying suspected coronary microvascular disease. And you can also more accurately determine the disease extent using a quantitative perfusion map. And lastly, I think this also opens up the possibility of doing follow-up studies and research because essentially now we can actually measure myocardial blood flow. We can use this as potentially a biomarker for identifying whether certain medications actually improve myocardial blood flow. So in terms of the diagnosis or using quantitative stress CMR for diagnosis and prognosis, there's already papers that have come out, and here's one from the UK where they were using a Siemens scanner, and this particular quantitative stress perfusion whip demonstrated that they could actually identify the difference between those that had normal coronary physiology, those with microvascular disease, and those with triple vessel disease. And here's just an example of what the maps look like. So if you have essentially normal coronary physiology versus coronary microvascular dysfunction or someone with triple vessel disease, you can see there's a gradual reduction in the amount of myocardial blood flow. And this is quite easy to perceive using a quantitative perfusion map. And this is just a diagram that they came up with advising on different cutoffs values that you could use. And they were focusing mainly on stress myocardial blood flow as the cutoff. Just across another part of London, Amadeo's group in King's College also were doing quantitative stress CMR, and this time it was on a Philips scanner. And they showed that essentially they could identify coronary microvascular dysfunction in patients that had no obstructive coronary arteries, but they were focusing mainly on myocardial perfusion reserve and actually showed better accuracy than stress MBF. So in terms of prognosis, again, over in London, they did a two-center study with just over 1,000 patients, and they showed that if you use quantitative stress perfusion, it was actually able to identify or differentiate patients that had worse outcomes. Now, these are actually not the original Kaplan-Meier graphs that were shown in the main manuscript. These two graphs are actually in relation to those that had non-obstructive coronary arteries. So it was showing that in patients that had non-obstructive coronary arteries, you could use stress MBF or MPR to identify a worse prognosis in those patients. Whereas the original Kaplan-Meier graphs, they showed that actually in all patients that are presenting with chest pain essentially had even stronger discrimination to identify those that had better or worse prognosis. So over in Hong Kong, we've been part of a multi-center international study group called the Aqua Consortium. And we've been providing cases in order to determine or to work on essentially a GE works in progress quantitative perfusion technique. And this particular study was looking really at the diagnostic accuracy of QP versus experts. So there were 4 experts, A, B, C, and D, and the average is based on this blue line. And what happened here was essentially we showed that compared to the red line and the gold line, which represented MPR and MBF, QP actually performs better than just standalone experts based on qualitative interpretation of stress perfusion maps. So how to perform quantitative perfusion? So this is usually the question people have after seeing a lot of the data coming out. And there are really 2 techniques by which you do this. One is the dual bolus technique, which means that it's a particular technique that requires 2 boluses of contrast for each perfusion acquisition. And this can be performed on any scanner. Now, the disadvantage of this is that you need a third-party software to analyze the images. And you also need to create 2 boluses of contrast. One is a 10% contrast bolus and the other is a 100% contrast bolus. For dual sequence, this is actually just based on a works in progress sequence. So you need to get this from essentially the vendor. And then this allows you to essentially acquire an additional sequence, which is known as the arterial input function sequence. And this means that you don't have to get the 10% contrast bolus in order to work out arterial input function. So the advantage of this is essentially it's like a single acquisition. It's the same way that you perform a stress perfusion. In some vendors, you may require additional software, such as GE, but in others, such as Siemens, you don't require additional software. It's all done in line, and the maps are produced automatically. So just to show you an example of how the dual bolus technique works, essentially what happens is you have a preparation stage. You fill essentially your tubing with 10% contrast bolus and you wait. And once you have reached adequate stress, you then inject with saline, and this basically flushes through, and you will get essentially what looks like a low contrast perfusion sequence. You will then have to repeat this again. So your nurse then fills the tubing with 100% contrast bolus, and then again, you inject with saline, and then you get a more traditional perfusion acquisition. So here's just another example of the 10% and 100% contrast bolus going through, as you can see here. And this is just an example of what a dual sequence looks like. So this is the arterial input function sequence that is acquired in addition and acquired very early in the RR interval. And you can see it's a lower resolution image because essentially all we need to do is to acquire the blood flow, the blood pool in order to determine the arterial input function. So here is a paper that we published where we were looking at the differences between dual bolus and dual sequence, because prior to this, it was uncertain whether actually dual bolus and dual sequence actually produce similar results. And what our study showed was that actually there are mostly similarities. There's definitely correlation, but in some particularly for stress MBF and rest MBF, there is a slight bias between essentially the dual bolus and the dual sequence technique. But when you look at the NPR, actually there is no bias between the dual bolus and dual sequence, and that's probably because stress MBF divided by rest MBF is your NPR, and the NPR therefore corrects for the bias. And here's just the correlation or scatter graphs. Okay, so I'll just go through a few cases. So here's a male in his early 30s. He's got good past health, presented palpitations due to SVT, and they wanted to do a stress CMR to exclude CAD or other pathology. And here you can see a stress perfusion and a rest perfusion sequence. And what you should appreciate on this is that there aren't any perfusion defects. So when we look at the quantitative stress perfusion, you can see that there is nice and perfusion on the stress images, and then on the rest images, you can see that there is reduced perfusion, and this comes out nicely on the stress MBF and NPR maps. So you can conclude that essentially there's no obstructive CAD or coronary microvascular dysfunction. So our second case is a male in his mid-50s. He's an ex-smoker, got asthma and hypertension. He presented with angina sounding chest pain, and 2 years ago he had moderate coronary artery disease, which was treated medically. And a recent CT showed LCX occlusion and moderate LAD/RCA stenosis, and they wanted to perform the stress CMR to help guide PCI intervention. So here you can see the stress perfusion images and the rest perfusion images in the bottom row. And what you can see here is there's a perfusion defect that's kind of appreciable on the qualitative images, but when you produce the quantitative perfusion images, it's much more obvious, the perfusion defect and its extent. And you can see this represented in the perfusion maps. So this patient clearly has obstructive CAD, and it's mainly focused in the LCX territory rather than really affecting the LAD or RCA territories. So this is a third case, as a male in his mid-60s, got type 2 diabetes, hypertension, hyperlipidemia. He's asymptomatic, so this is one of our research studies. And the coronary CT angiogram shows no narrowings less than, it shows narrowings, but they're less than 50%, and the patient underwent a stress CMR for research. So if we look at the stress perfusion images, you can see that there isn't any perfusion defect. But when you go over to the quantitative perfusion images, you can see that the patient actually has uniformly less or reduced perfusion. And it's not that much better than essentially the rest perfusion images. And essentially, this patient demonstrates evidence of coronary microvascular dysfunction. So this is a fourth case, a female in her mid-50s. She presents with atypical chest pain. And the CT 8 months ago showed high takeoff of the left main, but no coronary artery disease. And here you can see very clear coronary arteries on the CT. But the patient was a difficult patient. The cardiologist had been dealing with this patient for actually a long time. And she'd been complaining of pain, and they weren't entirely sure what to do with her. So they wanted to just do some more investigations, mainly because they just felt that that might help in terms of just convincing her that there was not much going on. So the stress CMR showed that actually there was very good perfusion. Actually, her perfusion was so good, it was very normal. But actually, on further questioning, there was a suggestion that maybe she has coronary vasospasm. So when they took her to the cath lab, you can see this is the baseline cath, and the patient then had acetylcholine challenge, and you can see that the LAD becomes very narrowed as a result of the acetylcholine challenge with ECG changes. And then when they give nitroglycerin, the patient then vasodilates, and the narrowing is overcome. So in terms of future challenges for quantitative stress perfusion, one thing that we don't actually know is whether there's a difference between the stress agents. So I'd say that in North America, there's a lot of regadenoson, particularly in the US, being used in comparison to adenosine, which is mainly favored in Europe. And there's also uncertainty whether there is whether we can actually compare the values across the three vendors. Furthermore, although we have done this study where we compared dual bolus and dual sequence in terms of the results and they show good correlation, we don't actually know whether there is a difference in terms of its performance, say from a diagnostic point of view or even from a prognostic point of view. And then there is also a push within the community to focus just on stress MBF only. And the reason for that is because obviously if you can drop the rest MBF images, or you can drop the rest perfusion acquisition, then essentially we could speed up our stress CMR examination. So there is interest moving in that direction. So just to conclude this portion of the talk, you should have an understanding of quantitative stress CMR. So you should understand about myocardial blood flow, myocardial perfusion reserve, and its automation. I've also covered about performing quantitative stress CMR with regards to performing it via dual sequence or dual bolus methodology. I've showed various clinical examples, and I've also covered briefly the future challenges. So I think at this point, I'm just going to stop and maybe allow you to ask any questions at this point. So before we move on to 4D flow, because I think this is probably a good point to stop before changing topics. So if anyone has any questions, I'm quite happy to take any questions now.
You know what? That's great. Thanks, man. You know what? Maybe we'll save questions at the end if that's all right.
Okay, sure.
Yeah, because if you're okay with that, yeah. So.
Oh yeah, no, I'm fine with that. I just thought it might just be a bit of a significant change in gears, but yep, no, happy to keep going on. So so at this point we'll move on to intraventricular flow. So for this particular talk, I'll introduce intraventricular 4D flow because I think people are aware of 4D flow as a concept, mainly focused on the big vessels. But I'll try cover what 4D flow is with regards to intraventricular flow specifically because it's a little bit different. I'll talk a little bit about normal values and then talk about its potential clinical uses. And then lastly, I'll cover some unanswered questions with regards to 4D flow, specifically intraventricular flow. So intraventricular flow is really a technique of measuring flow within the ventricle. And here's just a example of what you can see of essentially the software determining the intraventricular flow compartments. And these can be divided into four main components. One is direct flow, which is highlighted by the green color. Then there is delayed ejection, which is highlighted by the blue color. Then there is retained inflow, which is represented by the yellow color flow on the image. And the last is residual volume. Probably at this point, you're kind of wondering what all these mean. So I will try to illustrate this with this diagram here. So direct flow, so on the top row of images, this is in diastole, and the bottom row of images is in systole. So what this panel is trying to show you is that during diastole, the beginning of the cardiac cycle, the direct flow blood is actually sitting in the left atrium. But by the end of systole, all this blood should be now sitting in the aorta. So the idea of this is that direct flow represents blood that starts in the left atrium and by the end of the cardiac cycle is in the aorta. Delayed ejection, on the other hand, is essentially blood that starts in the left ventricle and at the end of the cardiac cycle, it's in the aorta. Retained inflow is blood that sits in the left atrium and by the end of the cardiac cycle, it's sitting in the left ventricle, while residual volume is blood that sits in the left ventricle and remains in the left ventricle at the end of that cardiac cycle. So there are just some things just to point out. So with intraventricular 4D flow, there are some things. Okay, so there is so in terms of 4D flow, there are some things just to note whenever you're looking at papers and you're wanting to kind of have a better understanding of what the data is showing you. There are some ways of checking that the 4D flow has been calculated correctly, such as checking that the direct flow and the delayed ejection together equal the ejection fraction, because that's what the two components should equal. Because as you can see here, both of them end with blood going into the aorta, and these are the only two compartments where blood enters into the aorta. And this is actually calculated based on the end diastolic volume. So essentially, the percentages for direct flow and delayed ejection are in relation to the end diastolic volume, or are a percentage of it, which is exactly what ejection fraction is. So your direct flow and your delayed ejection should equal your ejection fraction. Furthermore, your direct flow, delayed ejection, retained inflow, residual volume should equal your end diastolic volume. So all of these are given as percentages normally. You can actually acquire the volumes of each of these compartments to help you work out what the end diastolic volume is when all these four parameters are combined. So in terms of 4D flow, this is some early work that had come out early on when 4D flow, intraventricular flow was being looked into, and there was really some studies showing that essentially patients with DCM at night and ischemic heart disease had already shown increases in residual volume and decreases in direct flow. So this is just an example of what normal is meant to look like and what abnormal is meant to look like. There is also other things that we can get from the data, and one of them is kinetic energy. So for those of you that remember your physics back at school, essentially kinetic energy is half multiplied by the mass multiplied by the velocity squared. So here you can see the mass is essentially the voxel volume multiplied by the density of blood, and the velocity represents the velocity of each voxel. So when we're applying intraventricular 4D flow, I tend to make sure that the acquisition is just above the main pulmonary artery, and you want to also make sure that it's just below the right ventricle, because most of these techniques are done with free breathing. It's not really possible to, at least currently, it's not possible to acquire this so quickly in a single breath hold. So all these 4D flows need to be done in free breathing. Now, the time required depends on the vendor and the scanner technique, and the most important technique that actually is going to determine how long the 4D flow is going to require is actually your free breathing technique. So if, say, for example, you use a Siemens scanner, such as shown in this image, it will perform essentially a respiratory navigation, and in this green rectangle is where all the data will be acquired. And as you can see, if the acceptance rate is 50%, essentially it will take double the amount of time that it would typically acquire images if respiratory navigation was switched off. Whereas, say, for example, GE doesn't use a respiratory navigation, and Philips has the option of doing it both with respiratory navigation or without. So these are things you have to take into consideration when you want to determine how long you want to, or how much time you have to acquire the 4D flow. In terms of post-processing, there are various vendors that you can use for post-processing, but I'm just going to talk about the vendor that I use. And the way it's done is essentially you have to identify the mitral and aortic valve. And once these are delineated on every single cardiac phase, you have to determine what's known as the isovolumetric phase. So that's essentially the phase where the ventricle is in systole but is about to go into diastole, and you have to pick that phase so that the software can then perform the calculations. Okay, so at this point I'll talk about normal values. So there are already papers that are looking at normal values. This is one paper that was looking at essentially the Chinese population. Oh, sorry, no, this is actually this is their multi-center study. And here are just what the values look like for the LV flow components. And they also performed kinetic energy, but indexed to the end diastolic volume. And you can see here that across the age ranges, there isn't really any significant difference between the different decades, between direct flow, retained inflow, delayed ejection, and residual volume. But they found that for kinetic energy, across the decades, there is a more noticeable change when it comes to the E wave, A wave, and the kinetic energy EA ratio. So they also subsequently, in another publication, looked at the effect of ethnicity and sex. So they're wanting to know whether there was any significant differences between Asians and Caucasians when it comes to 4D flow. So if we just zoom in on the pertinent aspects of 4D flow, what they showed that actually between Asians and Caucasians, there actually really isn't much difference or any significant difference based on their sample size and for LV flow components. But for between males and females, they indicated that there might be some difference in terms of their retained inflow, and that for kinetic energy, at least for peak systolic kinetic energy, and peak E wave, there are potentially differences between males and females. So what are the potential clinical uses for intraventricular 4D flow? So one aspect that we have piloted using 4D flow is in heart failure with preserved ejection fractions patients. So this was actually a sub-study of a prospective trial that we were running. And what we wanted to know was whether you could use the 4D flow compartments as a way of identifying patients with HFpEF versus those that don't have HFpEF. And the ones that don't have HFpEF were essentially those that we suspected to have heart failure, but were shown to have preserved ejection fraction. And what we found was that essentially direct flow and residual volume were really the two best parameters in potentially identifying or differentiating HFpEF patients from non-HFpEF patients. So here's just an example of a patient with HFpEF. So what you can see is that the direct flow is just under 11%. So you can notice that there is a lot less green colored flow on this video compared to the non-HFpEF, where there is more green flowing into the left ventricle and out into the aorta. And the other parameter, which is residual volume, as you can see in HFpEF, there's much larger amount of residual volume compared to the non-HFpEF patients. And from a experience point of view of utilizing this sequence, we found that actually the heart failure patients actually cope relatively well with 4D flow because firstly, it's free breathing, so we don't have to tell them to hold their breath, which they normally struggled with. And the post-processing was relatively automated, apart from when you have to identify the mitral and aortic valves. So from that point of view, we thought actually this is potentially quite a useful technique, particularly in this group of patients. Our group then subsequently went on to look at all three heart failure categories. And what we found was that if we compared controls with HFpEF, HF-MREF, and HF-ref, so the mildly reduced ejection fraction and the HF-ref patients who have reduced ejection fraction, we found that the direct flow essentially reduces in the amount or percentage, and the residual volume increased in percentage in this study. And here's just the box plots charts showing you what the residual volume and direct flows look like across the four groups. And these are just some case examples. So you can see a patient who's an asymptomatic control, HFpEF, HF-MREF, and HF-ref, and you can see the reducing amounts of direct flow compared to the increasing amounts of residual volume as you go from controls to HF-ref. So another aspect of the study that we looked at was we looked at kinetic energy. So we looked at the full cohort, then we tried to balance the cohort for age and sex, and then we removed the atrial fibrillation patients to see whether this would have a particular effect on the kinetic energy values. And we found that essentially there wasn't really much changes by trying to balance it and then removing atrial fibrillation patients. And what we noticed is that from controls down to HF-ref, you'll notice that essentially the systolic wave starts to drop. And then as for the E and A waves, we also noticed that the E wave in particular started to flatten out, whilst the A wave was kind of becoming more or relatively higher compared to the systolic and the E waves in patients with HF-ref. And here's just another way of looking at it. So the previous one was actually a global kinetic energy, looking at all flow going through the left ventricle. And then when we broke it down into different compartments, so green being direct flow, blue being the delayed ejection, yellow being retained inflow, and red being residual volume, we found a similar appearance compared to the global. But in particular with direct and delayed ejection, you can notice that this makes up the systolic flow, not surprisingly, and these curves begin to flatten out. And then again, for the E wave, you can see that for the direct flow and the retained inflow, this E wave also starts to flatten out, whilst the A wave becomes more exaggerated relatively. So one question I've had from clinicians is, can you do it for the right ventricle? To which the answer is yes. So there's this group again from Singapore, and what they were looking at was tetralogy of Fallot patients, and they wanted to know whether the RV flow compartments was correlated with exercise performance as well as RVEF. And what we can see here is you can see that in terms of discriminating adverse RV remodeling, we can see that when you add RV direct flow, it actually improves the model, and it also became better at improving the model, predicting who had worse exercise capacity, as well as also based on which patients had higher risk based on risk scoring. So this is another group that was looking specifically at pulmonary arterial hypertension. So these patients don't have congenital heart disease. And what they found was that if you compare control group patients with pulmonary arterial hypertension, the direct flow decreases whilst the residual volume increases. So this brings me on to the final section of the talk. So there's some unanswered questions. One unknown is comparing 1.5 Tesla and 3 Tesla. We don't know if there's actually any differences between the two setups. We don't know if there's differences between prospective and retrospective gating, but you would suspect that there probably is, particularly because with prospective gating, you may miss out some of the diastolic flow. And the other issue is really the differences between signal averaging and respiratory gating. So for example, GE uses a signal averaging approach compared to Siemens, which pretty much exclusively uses a respiratory gating approach. And there's no actual clear delineation of which is superior. The other issue is also what is the optimal velocity encoding setting. So for example, the guidelines actually recommends 100 to 150, but I can tell you that from our personal experience over in Hong Kong, 100 actually has quite a bit of aliasing, and we're not very enthusiastic about 100. 150 generally works fine, but it does make me question whether the guidelines need to be updated with this regard, because 100 I don't find to be that helpful, and actually sometimes 200 tends to, in our experience, works better than 100. So studies need to be performed to determine what's the optimal velocity encoding. The other thing is also many of the studies are single center studies, so we need larger and multi-center studies essentially to confirm findings and also to have more robust data. The other issue is also to determine whether these results or whether 4D flow has prognostic information and whether this is useful for predicting outcome. So in conclusion, you should have a better understanding of intraventricular 4D flow in terms of the different compartments, as well as also kinetic energy and its acquisition. I've covered normal values. There is a multi-center study available, as I showed earlier. The only issue with that particular study is actually they use different scanners, so we don't actually know whether that is going to be an issue in terms of the results. There's also potential clinical use as demonstrated, hopefully from the examples I showed you from previous publications, particularly in heart failure and in pulmonary hypertension. And there remain some unanswered questions. So that I thank you for listening. I'll just leave you with an image of, this is the University of Hong Kong's medical school, and people are sometimes surprised to see so much greenery in Hong Kong. But actually 80% of Hong Kong is brown land or green land, which many people are surprised to find out, as was I. And also I'd just like to let everyone know that the FSCCT global meeting is actually coming to Hong Kong on the 23rd to the 25th of January 2026. And I hope to see some of you there. So thank you very much for listening.